Hello, folks, and welcome to the next chapter. We're covering chapter 20 on vital signs, which is a very common, very important practice for the medical assistant. So, some of the objectives to cover in this chapter is one, do the following related to temperature. Cite the average body temperature for various age groups. Describe emotional and physical factors that can cause body temperature to rise and fall. Convert temperature readings between Fahrenheit and Celsius scales. Obtain and record an accurate patient temperature using 3 different types of thermometers. Do the following related to pulse. Cite the average pulse rate for various age groups. Describe pulse rate, volume, and rhythm. Locate and record pulses at multiple sites. Do the following related to respirations. Cite the average respiratory rate for various age groups. Demonstrate the best way to obtain an accurate respiratory count. As far as blood pressure goes, cite the approximate blood pressure range for various age groups. Specify physiologic factors that affect blood pressure. Differentiate between essential and secondary hypertension. Interpret current guidelines and treatment. Describe how to determine the correct cuff size for individual patients. Identify different corticoff sounds. Accurately measure and document blood pressure. Discuss and perform pulse oximetry. Accurately measure and document height and weight and use the body mass index scale and convert kilograms to pounds and pounds to kilograms. Seems like a lot, but we will get through it. So almost every patient who visits the healthcare facility will have some vital signs measured. These signs are the body's indicators of internal homeostasis and the patient's general state of health. Medical assistants are often responsible for obtaining these measurements. It's crucial that they have confidence in the theory and practical application of vital sign measurements. A medical assistant who understands the principles of and the reasons for these measurements is a valuable asset to the healthcare facility. The vital signs are the patient's temperature, pulse, respiration, and blood pressure. These 4 signs are abbreviated TPR and BP and may be referred to as cardinal signs. Many organizations consider pulse oximetry or SpO2 a vital sign as well. The medical assistant must understand the significance of vital signs and must measure and record them accurately. Anthropometric measurements are not considered vital signs but are usually obtained at the same time as vital signs, including height, weight, and body mass index. So vital signs are influenced by many factors, both physical and emotional. A patient may have had a hot or cold coffee just before the examination, or may be anxious or fearful about what the provider may be finding. For example, consider the patient that's been asked to return for a repeat pap test because the first one showed abnormalities. The medical assistant measures the patient's blood pressure and finds it significantly elevated compared with previous readings. The patient may be anxious and concerned about the test results. The elevated blood pressure most likely reflects her anxiety. What impact would it have on temperature reading if a patient could not find a parking place and had to walk 4 blocks to the office, knowing that they would be late for the appointment? If you said it would be elevated, you're right. Certainly the patient's metabolism would increase because of the physical exercise, and as a result, his temperature would be elevated, along with his pulse, respirations, and blood pressure. The medical assistant should give the patient time to recover from his sprint to the office before taking any vital sign measurements. Vital signs are often altered if the patient has any pain. Pay attention to nonverbal signs that might indicate discomfort or pain, especially if the patient's blood pressure, pulse, and respirations are elevated. In addition, many patients are uneasy about being seen by the provider. This may alter vital signs. The medical assistant must help the patient relax before taking any readings. Measurements sometimes must be obtained a second time after the patient is more calm or comfortable. For a better picture of the patient's vital signs, the medical assistant may be asked to take the vital signs twice, at the beginning of the visit and just before the patient leaves the exam room. Body temperature is defined as the balance between heat lost and heat produced by the body. It's measured in degrees, in Fahrenheit or Celsius. The process of chemical and physical change in the body that produces heat is called metabolism. Body temperature is a result of this process. The core body temperature is maintained with a normal range by the hypothalamus. The average body temperature varies from person to person and is different in each person at different times throughout the day. In a healthy adult, this diurnal variation ranges anywhere from 97.7 to 99.5 Fahrenheit. 36.5 to 37.5 Celsius. The average daily temperature is 98.6 or 37 degrees Celsius. Body temperature is usually lowest in the morning and highest in the late afternoon. There are factors that may affect body temperature, including age, stress and physical activity, gender to deduce the effect of hormones, and external factors such as smoking, drinking, even chewing gum can elevate an oral temperature. Infection, either bacterial or viral, is the most common cause of fever in both children and adults. Infants don't usually develop febrile illness until the first 3 months of life, so if one is present, it's usually a very serious condition. There are patterns of fever that you should be familiar with. A continuous fever is one which rises and falls only slightly during a 24-hour period. The temperature consistently remains above the patient's average normal temperature range and fluctuates less than 3 degrees. There's intermittent fever, which comes and goes, alternating between elevated and normal levels. And then there's remittent fever, which fluctuates considerably by more than 3 degrees and never really returns to the normal range. Several types of thermometers and various sites can be used to take temperature readings. A digital thermometer can be placed under the tongue, in the armpit, or in the rectum. A tympanic thermometer is inserted to the ear, and a temporal artery thermometer is moved across the forehead. Temperatures can be either read in Fahrenheit or Celsius. Most digital thermometers can convert from one reading to the other. When an oral temperature is obtained, you do not have to indicate the site when documenting the reading of the patient's health record. If you use an alternate site, though, you should document the following identifiers, such as T for tympanic, A for axillary, R for rectal, and TA for temporal artery. Axillary temperatures are approximately 1 degree Fahrenheit lower than oral readings because axillary readings are not taken in an enclosed body cavity. Tympanic, rectal, and temporal artery temperatures are approximately 1 degree Fahrenheit higher than oral readings. The actual reading from the thermometer should be documented with the correct abbreviation for the site. Obviously, the oral site cannot be used with young children who can't close their mouth on command. Sometimes some big people can't do that either. This site requires the patient to hold the thermometer under the tongue and keep the mouth closed. A rectal temperature is most often used in infants. It's important to use the proper technique to avoid damaging the rectal tissue. However, most pediatricians prefer the infant's temperature be taken with a temporal artery thermometer because it's more comfortable for the baby, less invasive, and eliminates the possible complication of a perforated rectum. Most electronic health systems will automatically convert Celsius to Fahrenheit. However, you will be required to have a little bit of an understanding and some practice to do it manually. So to get the conversion from Fahrenheit to Celsius, to get the temperature in Celsius, you would take the temperature in Fahrenheit that you've obtained, subtract the number 32, and multiply it by 5/9. So you have to have a little bit of idea of how fractions work. To do just the opposite, to take your Celsius and convert it to Fahrenheit, you would take the reading that you got in Celsius degrees, multiply times 9/5, and then add 32. We will get practice during class on how to convert this, so hopefully it'll make a little more sense. Digital thermometers are battery operated. Disposable covers fit snugly over the probes and are easily and quickly removed by pushing in the colored end of the probe. The instrument sounds a beep when the process is complete in about 10 to 60 seconds, and the reading appears on the screen on the face of the instrument. Because the only part of the instrument that comes into contact with the patient is the probe, which is covered, the risk of cross-infection is greatly reduced. When using a digital thermometer to take an oral temperature, it's important to ask the patient, has it recently had anything to eat or drink or smoke? These factors may artificially alter the patient's temperature. Wait about 10 to 15 minutes before taking an oral temperature if those factors have occurred. In addition, the patient must be able to hold the thermometer under the tongue with the lips tightly sealed around the probe if an accurate oral reading is going to be obtained. Be sure to use the blue probe for the oral temperature. The tympanic membrane of the ear can be used for a quick, accurate, and safe assessment of the patient's temperature. It shares the blood supply with the hypothalamus, which is the brain's temperature regulator. So the ear canal is a protected cavity, which means factors such as an open mouth, hot or cold drinks, or even a stuffy nose don't affect the oral temperature. The tympanic thermometer system consists of a handheld unit equipped with a tympanic probe, which is covered with a disposable probe cover. When the probe is placed into the ear canal, it gently steals the external opening of the canal, and the sensor detects the infrared energy produced by the tympanic membrane. This signal is digitized by the thermometer and shown on the display screen. Accurate readings are obtained in less than 2 seconds. The tympanic thermometer is popular due to the speed in obtaining the temperature and the comfort that it affords the patient. This site should not be used if the patient is complaining of pain in both ears when the ear is touched. They may have bilateral ear infection or otitis externa, or if the patient has a history of earwax buildup, it may not get an accurate reading if that's what they're complaining of. The temporal artery thermometer uses an infrared beam to assess the temperature of the blood flowing through the temporal artery of the forehead, where the artery lies about 1 millimeter below the skin. Because the artery is so close to the skin, it provides good surface heat conduction, allowing the thermometer to obtain a fast, accurate, and non-invasive measurement of body temperature. To perform the procedure, place the probe in the center of the forehead, halfway between the eyebrows and the hairline. Bang should be pushed back off the forehead. Depress the button on the scanner and gently stroke the probe across the forehead toward the hairline at the temples, keeping the probe flat on the patient's skin. As the scanner moves across the forehead, repeated temperature measurements are taken, and the highest measurement is recorded. Keeping the button depressed, lift the scanner from the temporal area and lightly place the probe behind the earlobe. Release the button and remove the probe. Recording an accurate temperature takes about 3 seconds. Depending on the facility's infection control procedures, disposable covers can be used on the scanner, or it can be cleaned between patients with an alcohol wipe. A pulse rate may be counted any place an artery is near the surface of the body and the vessel can be pressed up against the bone. The most common pulse sites are the temporal, carotid, brachial, radial, femoral, popliteal, and dorsalis pedis arteries. The apical pulse is taken by listening with a stethoscope. The temporal pulse is located in the temple area of the skull, parallel and lateral to the eyes. It seldom uses a pulse site, but may be used as a pressure point to help control bleeding from a head injury. The carotid artery is located between the larynx and the sternocleidomastoid muscle on the front and side of the neck. It's most frequently used in emergencies to check a pulse during cardiopulmonary resuscitation, or if an unconscious patient is available. It can be felt by pushing the muscle to the side and pressing against the larynx. Only one side should be assessed at a time. The brachial pulse is felt at the inner or the antecubital aspect of the elbow. This is the artery that is felt and listened to when blood pressure is measured. It can also be felt in the groove between the biceps and the triceps muscles on the inner surface of the middle upper arm. This is the pulse that is checked on infants and young children receiving CPR. The radial artery is the most commonly used site for counting the pulse rate. It's found on the thumb side of the wrist about 1 inch below the base of the thumb. Femoral pulse is located at the site where the femoral artery passes through the groin. The examiner must press deeply below the inguinal ligament to palpate the pulse. The popliteal pulse is found at the back of the leg behind the knee. Palpation of this pulse requires the patient to be in the recumbent position with the knee slightly flexed. This is a very difficult pulse to assess. Most people can't find it, including specialists. The dorsalis pulse, or dorsalis pedis pulse, is the artery that's felt across the arch of the foot, just slightly lateral to the midline, beside the extensor tendon of the great toe. This pulse may be congenitally absent in some patients. Because a good pulse rate at this site is an indicator of normal lower limb circulation and arterial sufficiency, the provider usually checks these pulses in patients with peripheral vascular problems. The apical heart rate, or heartbeat at the apex of the heart, is heard with a stethoscope. It's used for infants and young children because assessing a radial pulse is usually difficult to palpate. An apical count may be requested if the patient is taking cardiac drugs or has a condition of bradycardia, which is excessively slow heart rate, or tachycardia, which is excessively fast heart rate. Rate, rhythm, and volume are all the factors assessed when taking a pulse. These characteristics vary with the size and elasticity of the artery and the strength and regularity of the heart's contractions. A patient's pulse can reveal valuable information about the cardiovascular system. The pulse rate is a measure of the number of beats felt from the movement of blood through an artery. When the heart contracts, blood is pumped into the arteries. The pressure throughout the arteries increases and the arteries expand. When the heart relaxes, little blood is moving through the arteries and arterial pressure decreases. Each contraction and relaxation of the heart muscle is a beat. The resulting expansion and relaxation of the arteries creates a pulsation. This is the pulse rate. Normally, the beat or rate and the pulse rate are the same. The rate of the pulse is the number of beats or pulsations that occur in 1 minute. Age, body size, gender, and health status can affect the pulse rate. The rate is also affected by individuals' activities and psychological state and the onset of certain medications. The pulse rhythm is the time between pulse beats. A normal rhythm pattern has an even tempo, which indicates that the intervals between the beats are of equal duration. An abnormal rhythm, or arrhythmia, is described according to the rhythm pattern detected. An intermittent pulse may occur in healthy individuals during exercise or after drinking a beverage containing caffeine. A common irregularity found in children and young adults is called sinus arrhythmia. The heart rate varies with the respiratory cycle, speeding up with the inspiration and slowing down to normal with expiration. If beats are frequently skipped or if the beats are markedly irregular, the provider should be aware, because this may indicate some form of heart disease. If an irregular rhythm is detected, the pulse should be counted for a full minute to ensure accuracy. A note should also be made when the patient's pulse was irregular. The volume or pulse amplitude or strength reflects the strength of the heart when it contracts. Volume can be assessed by feeling the strength of the pulse as the blood flows through the vessel. The force of each pulse is described as bounding or full, strong, normal, or thready, which means weak. The force of the heartbeat and the condition of the arterial wall influences the volume of the pulse beat. Pulse may vary only in intensity and otherwise may be perfectly regular. This condition can also indicate heart disease. Pulse volume is usually recorded using a 3-point scale. 3 plus indicates the pulse is full and bounding, almost like it's going to pop out of the site. It does not disappear with moderate pressure. 2 plus refers to a normal pulse. Pulsation that's easily felt but disappears with moderate pressure. 1 plus is a weak, thready pulse that's detectable but difficult to assess. And then 0 would indicate no pulse appreciated at all. I will not hold you to memorizing average rates and normal rates in different age ranges. This is why we have reference charts. Try to be familiar with it, but I promise you this will not be on any of your quizzes or exams that are given by me. And this is what we had just spoken about. So to record an accurate radial pulse, which is probably the most common pulse you'll be assessing, you must have the patient in a comfortable position with the artery to be used at the same level as or lower than the heart. The limbs should be well supported and relaxed. The patient may be lying down or sitting. As with all palpated pulse readings, the pads of the first 2 or 3 fingers are placed over the artery. Never use your thumb to determine the pulse rate. The thumb has its own pulse and you may confuse your pulse with that of the patient's. Push the radial artery against the bone until the strongest pulsation is felt. Both you and the patient should be in a relaxed position. Too much pressure is going to occlude or block off the artery, and too little pressure prevents detection of irregularities of other beats. While counting the rate, you must also be aware of the rhythm and volume. Variations from normal should be noted, such as arrhythmia or a pulse that is thready or bounding. Some pulses are more difficult to feel than others, and finding the correct pressure to be used for each patient and site requires repeated practice and experience. Pulses in the lower extremities may be difficult to find and assess and difficult to hear. Sometimes a provider, especially a specialist like a vascular surgeon, will use a Doppler unit or an ultrasound unit that magnifies the pulsation. It may be used to locate and count these pulses accurately. Respiration allows for the exchange of oxygen and carbon dioxide with the atmosphere, the blood, and the body cells. Oxygen is taken into the body to be used for life-sustaining body processes, and carbon dioxide is released as a waste product. One complete inhalation and exhalation is called a respiration. If you want to be more accurate, the proper term is ventilation. During the inhalation phase, the diaphragm contracts and drops down. The intercostal muscles pull the ribs up and outward. This causes the lungs to expand and fill with air. During the exhalation phase, the diaphragm returns to its normal elevated position and the intercostal muscles relax. This causes the lungs to expel the waste of air out of the body. Both internal and external respirations occur. External respiration is the exchange of oxygen and carbon dioxide in the lungs, whereas internal respiration occurs at the cellular level. Oxygen in the bloodstream is transferred into the cells and used with sugars and fatty acids to produce energy. Carbon dioxide is released as a waste product and transported back to the lungs for exhalation and release from the body. The respiratory center in the medulla oblongata is very sensitive to changes in blood oxygen and more so carbon dioxide levels. When carbon dioxide levels rise, the respiratory control center sends a message that triggers breathing. Respiration is controlled by the involuntary nervous system. This means that we breathe automatically. Because respirations can be controlled to a certain extent, it's also a voluntary function. However, breathing ultimately is under the control of the medulla oblongata. This is why we can hold our breath only for a short period of time. Once cells become oxygen starved, a stimulus is sent to the respiratory muscles and breathing begins involuntarily. Normally, a person's breathing should be relaxed, automatic, and silent. However, respiratory disease or chronic conditions can influence the characteristics of an individual's respirations. The term dyspnea occurs in patients with pneumonia, asthma, or chronic obstructive pulmonary disease, or COPD. It also occurs after physical exertion at very high altitudes. Other alterations in breathing are bradypnea, which is slow breathing, apnea, which is absent breathing, tachypnea, which is rapid breathing, and hyperopnea, which is usually very heavy breathing. Hyperopnea usually is accompanied by hyperventilation and often occurs when the patient is extremely anxious or in pain. Orthopnea is a term that frequently occurs in patients with congestive heart failure, where they have a difficult time breathing while they're lying in a supine position. Wheezing signals difficulty breathing in patients with asthma, but not always asthma. When assessing a patient's respirations, you most should note three important characteristics: rate, rhythm, and depth. The rate of respiration is the number of respirations per minute. A ratio of 4 pulse beats to 1 respiration is usually typical. As a rule, both pulse and respiratory rates respond to exercise and emotional upset. Rhythm refers to the breathing pattern, the space between each breath. A regular breathing pattern is normal in adults. However, the breathing pattern for infants varies. Autonomic interruptions such as sighing are also considered normal. The terms regular or irregular are used to document breathing rhythm. Then when you take a look at the depth of respiration, you're looking at the amount of air inhaled and exhaled. When a patient is at rest, normal respirations have a consistent depth, which can be noted as you watch the rise and fall of the chest. Rapid shallow breathing at rest occurs with some diseases, such as asthma and emphysema. And again, have a good idea of the different age ranges and normal rates between age ranges, but you will not be held to memorize these numbers. Because most people can control their breathing to a certain extent, it's best not to mention that you'll be counting the person's respirations. Patients may self-consciously alter their breathing rate when they know they're being watched. Because remember, there is some voluntary control over your breathing rate as well. Count the respirations while appearing to count the radial pulse. Keep your eyes alternatively on the patient's chest and watch while you count the pulse rate. Then, without removing your fingers from the pulse site, determine the respiratory rate. And again, record variations on the patient's chart. It's typically best to count for 30 seconds and multiply by 2. However, if the breathing is difficult to assess or profoundly irregular, count for the whole minute. A blood pressure reading reflects the pressure of the blood against the walls of the artery each time the ventricles contract. When a ventricle contracts, blood is pushed out of the heart and into the aorta, exerting pressure on the walls of the artery. There are actually two blood pressure readings. The systolic blood pressure is the highest pressure level that occurs when the heart is contracting and is the first heart sound heard. The diastolic pressure is the lowest pressure level when the heart is relaxed and is the last sound heard. So if you typically get your blood pressure read as 120/80, the systolic blood pressure is the 120, and that's the pressure on the wall of the artery as the heart is contracting. The bottom number, the 80, is the diastolic blood pressure, which is the pressure on the wall of the artery as the heart is relaxed or in diastole. Systole and diastole, heart contraction and relaxation, together make up the cardiac cycle. The difference between systolic and diastolic pressure is called the pulse pressure. Blood pressure is read in millimeters of mercury, abbreviated mmHg. However, you maybe not need to include the abbreviation when documenting the reading of the patient's health record. Again, blood pressure is recorded as a fraction, with the systolic reading served as the numerator and the diastolic reading served as the denominator, or the bottom number. Again, just like I'm going to say, there's very little hard numbers that you have to memorize. Just get a general idea of what's normal and abnormal for different age ranges. Some factors that determining blood pressure include blood volume, peripheral resistance, vessel elasticity, and condition of the heart muscles and the arterial walls. Volume is the amount of blood in the arteries. An increased blood volume raises blood pressure, and a decreased blood volume lowers blood pressure. With extensive bleeding or hemorrhage, the blood volume drops, and so does the blood pressure. And with that, some types of blood pressure medications that are designed to lower blood pressure are meant to do so by reducing the volume of fluid in the cardiovascular system by enhancing urination. The peripheral resistance of blood vessels refers to the lumen, or the diameter of the vessel, and the amount of blood flowing through it. The smaller the lumen, the greater resistance to blood flow. Blood pressure is higher with a smaller or reduced lumen and lower with the large lumen. Vessels affected by fatty cholesterol deposits or atherosclerotic plaques become narrower over time. This results in smaller vessel lumens and therefore higher blood pressure. Vessel elasticity is the ability of an artery to expand and contract to supply the body with a steady flow of blood. With advancing age, certain lifestyle factors, and the presence of arteriosclerosis, vessel elasticity may decrease. This causes the arterial wall to become firm and resistant, increasing blood pressure. And the condition of the myocardium, or the muscle of the heart, is a primary determinant of the volume of blood flowing through the body. A strong, forceful contraction empties the heart and tends to keep the blood pressure within normal limits. If the myocardium is weak, pressure in the vessels begins to increase in an attempt to maintain an adequate level of circulating blood to meet the oxygen and nutrient needs of the body. So hypertension can occur in children or adults, but individuals of African American descent, middle-aged and older adults, patients with diabetes, and those with kidney disease are at greatest risk. Hypertension is often called the silent killer because it frequently has no symptoms. Individuals can go for long periods of time not knowing they have a problem. When they use the term essential hypertension, it's the most common type of hypertension. It's something we call idiopathic, meaning we don't really know what's causing it. But it's associated very highly with obesity, high levels of sodium, elevated cholesterol levels, family history, and various races such as African Americans, Native Americans, Mexican Americans, Native Hawaiians, and some Asian Americans also have a high concordance of hypertension. Secondary hypertension is usually caused by some underlying pathologic conditions such as renal disease, complications of pregnancy, endocrine imbalance, or even some type of brain injury. Temporary hypertension may occur with stress, pain, exercises, or even exhaustion. Some patients may experience what we call white coat syndrome. Their blood pressure becomes elevated in the medical environment due to anxiety, but it's usually normal when they're away from their healthcare facility. Individuals with prehypertension should be diagnosed and encouraged to make healthy lifestyle changes before they require treatment or move into the hypertensive category. The American Heart Association recommends limiting one's intake of salt and eating a diet rich in potassium, calcium, magnesium, and protein while reducing total fat intake, especially saturated fat. Individuals with prehypertension should also restrict their alcohol intake, engage in regular physical activity, and lose weight if necessary to maintain a healthy BMI, or body mass index. Many times, just losing 10% of a person's weight lowers their blood pressure. In people older than 50 years old, the systolic reading is more important than the diastolic reading. Individuals over 50 should be treated if they have systolic pressure over 140 millimeters of mercury or higher, regardless of their diastolic blood pressure. Medical treatment at this age can reduce the development of cardiac and kidney disease later in life. Most patients with hypertension require 2 or more medications to achieve desired blood pressure levels. The goal of treatment is to maintain a blood pressure below average of 140 over 90 or below 130 over 80 in patients with diabetes or kidney disease. Patients should be treated with a diuretic or a water pill to help excrete excess amounts of fluid and sodium and some other type of antihypertensive medication. A patient-centered treatment approach should be implemented to motivate patients to maintain compliance with hypertension management. The medical assistant can play an active role in establishing a therapeutic relationship with the patient by providing ongoing education and support to ensure compliance with provider-recommended treatment. Using community resources such as local dietitian referrals may also help patients comply with treatment. The instrument used to measure a blood pressure is called a sphygmomanometer. Sphygmomanometer. No, I will not require you to spell that. Very simply, a blood pressure cuff. It consists of an inflatable cuff, an inflation bulb with a control valve, and a pressure gauge. The blood pressure mechanism consists of an aneroid dial attached to an inflatable cuff. The device may be handheld, wall-mounted, or floor model. Some systems have a trigger-style air release valve. These can be pumped up and the air slowly released by pushing the trigger. With more traditional sphygmometers, the valve must be unscrewed, which requires a little bit of manual dexterity. Blood pressure cuffs are to be delicately calibrated instruments and must be handled carefully. They should be recalibrated regularly and checked for accuracy by the medical assistant or the medical supply dealer. The needle on the aneroid dial sphygmometer should rest with a small square or circle at the bottom of the dial. If the dial is not correctly calibrated, the patient's blood pressure reading will be inaccurate. The blood pressure cuff, I'm sorry to say sphygmometer, must be used with a stethoscope. The goal of the procedure is to use the inflatable cuff to stop the circulation through the artery. The stethoscope is placed over the artery just below the cuff. As the cuff is slowly deflated to allow the blood to flow again, cardiac cycle sounds are heard through the stethoscope and readings are taken with the first systolic and the last diastolic sounds that are heard during the procedure. To obtain a correct blood pressure reading, the cuff must be the proper size. The systolic and diastolic blood pressure can be lowered by as much as 5 millimeters, however, of mercury if the cuff is one size larger than appropriate, and the blood pressure can be elevated by up to 6 millimeters of mercury if the cuff is one size smaller. The inflatable part, or the bladder of the cuff, must be the correct size and should cover about 80% of the circumference of the upper arm. To help with this, most blood pressure cuffs have predetermined markings on the internal side. As long as the cuff is secured within these lines, it should be accurate. Blood pressure is usually taken with the patient in either the sitting or the supine position. However, the diastolic pressure can be as much as 5 millimeters of mercury higher when the patients are sitting than when they are supine. In addition, if the patient's back is not supported and there is some muscle tension in the body, the diastolic pressure may be increased by up to 6 millimeters of mercury. If the patient crosses their legs during the reading, the systolic pressure may be artificially raised by 2 to 8 millimeters. The position of the patient's arm can also have a major influence when the blood pressure is measured. If the upper arm is below the level of the right atrium, in other words, dangling at the patient's side, the reading is artificially elevated. If the arm is above the heart level, the reading is artificially lowered. If the patient holds up the arm, muscular tension will also raise the pressure. The arm should be placed at the level of the heart, on the table next to the exam room, or resting on the arm of the chair to avoid these issues. Many times blood pressures are taken incorrectly, and common causes of errors in blood pressure readings include the following. Either the limb used for measurement is above or below the level of the heart. The bladder in the cuff is not completely deflated before a reading is started or retaken. The pressure of the cuff is released too rapidly. Patient is nervous or anxious. Patient drank coffee or smoked cigarettes within 30 minutes of the measurement. The cuff was applied improperly, or the cuff was too large or not placed around the arm. Or the reading was taken over and over and over again with a failure to wait 1 to 2 minutes between measurements. The Korsakoff sounds are what we are going to listen for and what we're going to try to appreciate as we practice taking blood pressures. Korsakoff sounds are the sounds heard during auscultation of blood pressure. Vibrations of the arterial wall produce these sounds when the blood surges back into the vessel after it has been compressed by the blood pressure cuff. Phase 1 is the first sound heard as the cuff deflates. The blood is resurging into the patient's artery and can be heard clearly as a sharp tapping sound. This is when you want to note the gauge reading when the first sound is heard. This is recorded as a systolic blood pressure. As the cuff deflates, even more blood flows through the artery. The movement of the blood makes a swishing sound. If you did not follow proper procedure in inflating the cuff, you may not hear these sounds because of their soft quality. Occasionally, blood pressure sounds completely disappear during this phase. Loss of the sounds followed by reappearance is sometimes called an oscillatory gap. The silence may continue as the needle falls another 30 millimeters of mercury. Oscillatory gaps usually occur in hypertension and certain types of heart disease. In phase 3, a great deal of blood is moving down the artery. The distinct sharp tapping sounds return and continue rhythmically. If you do not inflate the cuff enough, you will miss the first 2 phases completely and you'll get an incorrect interpretation. At phase 4, the blood is flowing easily. The sounds change to soft tapping, which becomes muffled and begin to grow fainter. At phase 5, all sounds disappear. Note the gauge reading when this occurs because that is going to be the reading of your diastolic pressure. The systolic pressure may be checked by feeling the radial pulse rather than hearing it with the stethoscope. When placing the cuff in the usual position and palpate the radial artery, noting rate and rhythm. Inflate the cuff until the pulse disappears, then add about 30 millimeters more to the inflation to get above the systolic pressure. Do not remove your fingers from the pulse or change the pressure of your fingers. Carefully watch the gauge while slowly releasing the pressure in the cuff and wait till you feel the first beat. Note the reading of the gauge and document the first pulse felt as the systolic pressure increases. This is not completely accurate means of obtaining the systolic blood pressure, but it can give you a reasonable idea of where the systolic blood pressure occurs. Note, this method cannot determine the diastolic blood pressure. Pulse oximetry is a non-invasive method of evaluating both the pulse rate and the oxygen saturation of the blood. It may also be referred to as saturation of peripheral oxygen, or what's written as SpO2. Many ambulatory settings use pulse oximeters to assess a patient's oxygenation status in disorders such as pneumonia, bronchitis, emphysema, or asthma. To perform the procedure, the medical assistant clips a probe on the patient's earlobe or finger. Fingernail polish must be removed before the clip is applied. If the patient has artificial nails, the earlobe should be used. A beam of infrared light passes through the tissue, and the amount of light absorbed by oxygenated hemoglobin is measured. This is displayed on a digital screen as a percentage. At the same time, the light measures the patient's pulse rate, which is also shown on the screen. A normal pulse oximetry reading is about 95% or higher. Treatments such as oxygen or bronchodilator therapies usually started when readings are 90 to 92% or lower. Anthropometry is the science that deals with measurement of the size, weight, and proportions of the human body. These measurements often are included in the initial recording of vital signs and before the provider performs a physical examination or well baby check. Because they're indications of the patient's state of health and well-being, height and weight measurements and the associated body mass index are discussed as aspects of the vital signs. And just like with temperature, there needs to be an understanding of how to convert pounds to kilogram. So 1 kilogram equals 2.2 pounds. So you multiply the number of kilograms by 2.2 and that gives you the number of pounds. And just the opposite, converting kilograms to pounds, 1 pound equals 0.45 kilograms. So multiply the number of pounds by 0.45 or divide the number of pounds by 2.2 and that will give you the conversion. Again, if that makes your head a little bit dizzy, we will get practice and go over it during class. And so in closing, measuring and documenting vital signs are a crucial part of the medical assistant's responsibilities. You must keep in mind that the results can cause the patient anxiety and concern. For example, if you have a patient who's struggling to maintain a healthy blood pressure, it's important that you're sensitive to his or her concerns. If you have a patient who's having difficulty maintaining or losing weight, he should be quite apprehensive or embarrassed or even depressed about the weight results. Being aware of the patient's concerns about vital signs and showing sensitivity to his or her needs are part of being a medical assistant. And if any questions, please bring them to class or post them on the discussion board. And have a great day.